Hi everyone, thanks for listening in. This is actually a rerun of the presentation I gave at Partnership Opportunities and Drug Delivery Conference last year. We're excited to be attending POD again this year on the 16th and 17th of October and look forward to meeting with everyone in Boston. My name's Steve Gowers. My personal background is actually in human-centered design, and I'm currently responsible for the drug delivery and digital health activities here at TTP. I joined TTP around 12 years ago now. The topic of biologic delivery has been central to so many of our projects and conversations over the years. Shifting care setting from hospital to home has become the norm for a broad range of conditions. Subcutaneous self-administration of biologics is often a key part of that. For some time now, there's been an overarching trend towards larger volume, highly viscous formulations, often long-acting, and we've also observed the emergence of more complex biotherapeutics, in some cases dual therapies, often difficult suspensions which have very specific delivery challenges. There are a broad range of devices available to customize, but this space has become more challenging than ever before, and deciding how best to deliver your formulation is actually very difficult. So I wanted to tell a story that I suspect many will resonate with, and it will hopefully help you as you reflect upon these challenges. It's a story that evolves around what we've affectionately called the ziggurat of misery. Michelle, who leads a device team, has been approached by the drug product team about a new, super exciting molecule that's coming through the pipeline. Michelle is tasked with trying to navigate through a maze of different decisions on multiple levels, each of which is influenced by the decisions you made in the last level. Ultimately, she needs to decide upon the best possible way to deliver the formulation. Her journey starts in the formulation zone, which is understandably where most device teams are forced to start, as the formulation is often still a moving target. For lower volume, lower viscosity formulations, there was rarely too much to worry about. 1 to 2 milliliter formulations are well suited to existing auto-injectors or pre-filled syringes. It's relatively quick and easy to infuse into the skin. The formulation flows through the porous medium in the soft tissue and is gradually absorbed. This is what's known as Darcy flow and is well documented in the literature and well understood. However, the formulation that Michelle is trying to pin down is much larger in volume and quite highly viscous. How the formulation is infused into the skin suddenly becomes a lot more critical. Darcy flow becomes less relevant, particularly at viscosities of 10 centipoise and greater and volumes of 10 ml plus. If you're still trying to infuse this relatively quickly, you essentially get fracking. Tissue will start to deform elastically and fracture to make space for the formulation. TTP has conducted several programs now to model the biomechanics of infusing formulations of different volumes and viscosities. Only when you understand how the skin behaves can you begin to understand things like back pressure, which is obviously important, particularly for pressure-driven devices, because this is a key part of understanding infusion times. Of course, there's always the option to go slower, which avoids fracking. At this point, absorption by the capillary and lymphatic system becomes more predictable. So Michelle is faced with the choice of 3 formulations as she attempts to advance to the next zone. 5 milliliters, which would be extremely viscous, 10 milliliters, which would become slightly less viscous, or 20 milliliters, which would be less viscous again, but which obviously brings different considerations when it comes to the device. Is the physics zone. Once you've started to pin down the formulation and understand how it might interact with the body, the next step is often to try and understand how this is likely to behave in a delivery device. Delivery time is driven by the volume and viscosity of the formulation, but also bursting pressure in the cartridge, length of the needle, inner diameter of the needle. The graph shows delivery times for 3 different formulations. As your needle gauge gets higher, i.e. the inner diameter gets smaller, it takes longer to push the formulation through the needle. Here you see 5 different needle sizes that Michelle might be considering. Jumping from a 27 extra thin wall to a 32 thin wall might offer benefits to a patient, but comes with a cost as it increases the time it takes to deliver the 5 ml formulation from 20 seconds to 20 minutes. Of course, this is only a basic model that doesn't take into account viscous losses in the needle. Importantly, it also doesn't take into consideration the biomechanics of the skin and related back pressure, something Michelle faced in the previous formulation zone. Formulations are often complex and non-Newtonian. Mechanical test rigs, like the one shown here, are often helpful to characterize these behaviors. They also serve to help assess forces, help select drive component options, and calculate drivetrain efficiencies. So Michelle has built a bit more of an understanding going through the physics zone. She could go for a 5 ml formulation, which could open the option of large auto-injectors, but infusion time is likely to take 20 to 43 seconds. Another option could be 10 milliliters and a thinner needle, which would require 3.5 minutes infusion, potentially a good design point for an on-body. Lastly, she could go for a 20 milliliter formulation, opt for a super thin needle, and accept that the infusion experience may last close to an hour. Thankfully, Michelle made it through the physics zone and is now in the usability zone. A lot of the challenges associated with usability and patient preference require you to conduct research to better understand the people who will ultimately be using the device. At TTP, we've been really interested in these topics for quite some time. We recently conducted a user study with biologics users to better understand some of the usability considerations and patient preferences when it comes to auto-injectors and on-body devices. Dose frequency and duration featured as the most important factors, much more important than things like device size. One of the most important things when considering dose duration was actually how taking a medication might fit into someone's routine. Most participants administered their drug in the evenings, after dinner, or before bedtime. If they were to consider a larger volume injector, the frequency and duration would need to fit within this schedule. Since there are now 5 milliliter auto-injectors available, we asked participants to go through simulated use on different injection sites and hold the auto-injector in place for up to 60 seconds. We asked them to rate their comfort levels at different intervals through the 60 seconds. This is the graph you see. Comfort clearly decreased over the period. There was also a clear preference for thigh and abdomen sites over the back of the arm. There are physical considerations, but also psychological ones. One participant actually considered holding the injector for that long psychologically difficult. But of course, it's not just what people say, it's what you observe them do. What was most surprising was the grips that different users adopted, knowing that they were going to be required to keep the auto-injector in place for up to 60 seconds. 5 milliliter auto-injectors have the same form factor as smaller variants, but handling over longer infusion times is likely to be very different. Stability was a big issue, particularly for people suffering from rheumatoid arthritis. This video shows part of that struggle. What you can't see is actually the fatigue and tension on the face of the participant. So now that Michelle has a better understanding of patients, she has a choice of which type of device to go for. For the 5 milliliter option, there's the choice of 2 more traditional 2.25 ml auto-injectors, or she could opt for a larger 5 ml auto-injector, recognizing that infusion times are likely to be much longer. For the 10 milliliter option, she could go down the route of an on-body injection platform that infuses over a few minutes. Alternatively, there's a 20 ml slow infusion option with a personal belt-worn device. Last, but certainly not least, it's the adherence zone. This is at the top of the pyramid and often one of the last things that drug and device teams consider. It's certainly one of the most challenging things to consider, and it's very hard to test hypotheses related to longer-term engagement. There's a lot of research out there and several frameworks to help think about this topic. Ultimately, it often comes down to how easy people perceive something to be and how much value they are able to get from it. Many of the things we've already discussed have a direct impact on how likely someone is to take their medication. Number of medications and dose frequency have both been shown to have a strong correlation with adherence and persistence levels in many disease areas. Other things such as convenience, habits, ease of use and feedback are all important as you consider device options. Quite often, we begin to talk about digital solutions to support adherence. We've developed a design toolkit aimed at stimulating the design of solutions that take some of these key factors into consideration at the earliest possible stages. So Michelle made it through the maze to the top of the pyramid. However, making decisions sequentially can often lead to dead ends. What we advocate is that you should always consider these factors holistically right from the start and leave as many options open as possible for as long as possible. If this is a journey that's familiar to you, please get in contact or come and talk to us at Pod.